So today we are going to start another very important endocrine gland, which is the parathyroid gland. And developmentally they are derived from pharyngeal pouches that also give rise to thymus. So they share thymus and parathyroid gland. They share a common developmental origin. They are most commonly located in close proximity to the upper and lower poles of each thyroid lobe. So you know that thyroid is like this lobe structure, and then they are present at the upper and lower extremities of the thyroid gland. So they are very intimately, closely attached to the thyroid gland, and that is an important anatomical feature to remember. Okay, they are most commonly located in the close proximity to the upper and lower poles of each thyroid lobe, but may be found anywhere along the pathway of the descent of the pharyngeal pouches. So ये आपको बात पता होनी चाहिए कि although they are routinely present at the poles of the thyroid, but they can actually be present anywhere in the descent pathway embryologically. Most of the gland is composed of the cells which are known as chief cells, which have secretory granules which contain PTH. So PTH is their hormone. So if this is a parathyroid gland, the cells will be known as the chief cells, and they will be releasing PTH, parathormone. Okay. Another category of cells in the parathyroid are called the auxophil cells, and they are found throughout the normal parathyroid, either singly or in small clusters. They are slightly larger than the chief cells, and they have acidophilic cytoplasm, and they are tightly packed with mitochondria. So two types of cells that you have to remember. और thyroid gland के साथ ये जो parathyroids attached हैं, इनमें से chief cell release करते हैं PTH. So that is and what is the job of the PTH? It's mainly involved in calcium metabolism. Okay, so parathyroid glands are key regulators of calcium homeostasis in the body. The activity of the parathyroid gland is controlled by the level of free ionized calcium. So कितना calcium body में मौजूद है वो control करेगा कि कितना PTH release होगा. Normally, decreased levels of free calcium stimulate the synthesis and secretion of PTH ताकि ये calcium को absorb करवाए. So if this is your body and you are in a situation जहां आपकी body में calcium कम है, free calcium, then this is a very good stimulus for parathyroid to release PTH, and the PTH will go to different parts of the body, such as the gut, such as the bones, and it will try to increase the levels of calcium. So you see how reduced calcium stimulated PTH, and then calcium levels go up. That sort of feedback mechanism is important for you to remember for parathyroids. Okay. And parathyroid will perform its function on different places. So for example, it goes to the kidneys and increases the reabsorption of calcium. It goes to different other parts of the body. So increased urinary phosphate excretion also happens in the kidney. So kidney पर दो actions हो रहे हैं. What's happening is कि calcium की reabsorption increase हो रही है ताकि body में ज़्यादा calcium आए, and then there is increased excretion of phosphate. इससे क्या होगा? Thereby lowering the serum phosphate level, since phosphate binds to ionized calcium. So what's actually happening is if these are your kidneys, the PTH goes in there, it asks for more phosphate secretion. मैं ये बार-बार students को बताता हूँ. Phosphate trashing hormone. There's an easy way to remember. PTH increases phosphate excretion, because अगर phosphate body में ज़्यादा होगा, so it will obviously bind with calcium, and if it binds with calcium, the calcium levels will go down. And at the moment, PTH's job is to increase the calcium level. So it increases calcium reabsorption through the kidney, and it increases phosphate excretion. Okay. Parathyroid hormone also increases the conversion of vitamin D to its active dihydroxy forms in the kidney, which in turn augments the GI absorption of, that's an indirect function of PTH to increase calcium absorption from the gut via vitamin D activation. It also goes to the bone and increases the osteoclastic activity. Therefore, calcium is released from the bone. So the net result of all these activities is increase in the level of free calcium in the blood. And once the levels of calcium go up in the blood, it kind of then have a negative feedback on the parathyroid. So it negatively stops or negatively controls the release of PTH. Abnormalities of the parathyroids include both hyperfunction. When it is hyperfunction, we call it hyperparathyroidism, which is the topic today, and then hypofunction, which is when the parathyroid glands are working less. And then there are also tumors. They usually come to attention because of excessive secretion of PTH rather than any mass effect. So, thyroid gland की जो tumors हैं, they cause obviously clear mass effects, but tumors associated with parathyroid are largely because they are secreting a lot of PTH. Okay, so now we will consider a situation where we have increased PTH. So increased PTH is what we call hyperparathyroidism, which comes in two major flavors. Number one is called the primary and the other one is called the secondary. And then there is actually three flavors, the tertiary hyperparathyroidism as well. The first condition represents an autonomous, spontaneous overproduction of PTH, while the later two conditions are secondary phenomena because of something else. And we'll talk about them in a minute. So, primary hyperparathyroidism, something is wrong primarily within the gland. It's a common endocrine disorder and an important cause of hypercalcemia. Now, you know, ये मुझे बार-बार नहीं बताना आपको कि if there is more PTH being released, obviously there will be more calcium in the body because that's the job of the PTH. Okay? So there will be hypercalcemia that's inherent and that comes with hyperparathyroidism. There was a dramatic increase in the detection of the cases in the later half of the 20th century, mainly due to routine performance of serum calcium assays in the hospitalized patients. So check करना शुरू किया लोगों को, incidental finding पता लगा बहुत से लोगों को hyperparathyroidism है. The frequency of occurrence of various parathyroid lesions underlying hyperparathyroidism are, number one, the most common is adenoma. So the parathyroid gland, the cells go, they increase in number, they hyperfunction, forms an adenoma. That's the most common cause of hyperparathyroidism. Then there is diffuse or nodular hyperplasia, which is not in the tumorous form, but still there is hyperplasia. So that accounts for about 5 to 10% of the cases. And then very rare, but parathyroid cancer can also cause increased PTH. Okay. Abnormalities in the two genes commonly associated with parathyroid tumors are, number one, cyclin D1. Is gene में rearrangement हो जाती है. It's a positive regulator of the cell cycle. And inversion on chromosome 11. Repositions in cyclin D1 gene so that it resides adjacent to the genomic element that regulate the PTH. So there is a rearrangement of the gene which goes near the locus of PTH and hence, which is present on chromosome 11 by the way, and therefore there is overexpression of PTH. So that's one genetic abnormality which you have to remember about parathyroidism, primary. The other one are the MEN mutations. These are multiple endocrine neoplasias, and these mutations account for about 20 to 30% of the sporadic parathyroid tumors, having mutations in both copies of MEN1. The spectrum of MEN1 mutation in sporadic tumors is virtually identical to that in familial parathyroid adenoma. So two mutations you must remember, okay? MEN and cyclin D1 for primary hyperparathyroidism. Then the clinical features, how does the patient, and then I'll come back to the gross features, but how do these patients come to you clinically? Obviously, think about they have increased PTH and obviously they have increased calcium. So the primary hyperparathyroidism usually is a disease of adults and is more common in women as compared to men. 4:1 ratio. The most common manifestation of primary hyperparathyroidism is an increase in serum ionized calcium. Obviously, there will be increased calcium. That's the hallmark of the disease. In fact, primary hyperparathyroidism is the most common cause of clinically silent hypercalcemia. So there is more calcium, patients don't even know. Remember at the start of the chapter I just told you they were incidentally identified in hospitalized patients because the screening was suddenly started. The most common cause of clinically apparent hypercalcemia in adults is cancer, which can cause hypercalcemia through a variety of mechanisms, including not only the PTH secretion, but also like PTH-like polypeptides. And because there is a tumor, think about it. So these are parathyroid glands secreting continuously PTH and that going continuously to your bones and continuously releasing calcium from there. So यहाँ एक्चुअली ऑस्टियोलाइटिक लीजन्स बन जाते हैं बिकॉज सोचे ना इसमें से बार बार कैल्शियम निकाला जा रहा है परसिस्टेंटली, तो बोन का क्या हाल होगा, बोन पूरी सुराख हो जाएगी. सो दैट्स व्हाट हैपेंस इन कैंसर पेशेंट्स. The prognosis for the patient with malignancy-associated hypercalcemia is not good because it often occurs in those with advanced cancers. In individuals with hypercalcemia caused by parathyroid hyperfunction, serum PTH is inappropriately elevated, where serum PTH is low and undetectable in those with hypercalcemia caused by non-parathyroid disease. So that's an important one. So, and that's very logical. So if there is something wrong within the parathyroid gland, there will be more PTH because that's the pathology. But if, say for example, I have a tumor elsewhere in the body and it is not in the parathyroid gland and this tumor is releasing parathyroid like hormone, not exactly parathyroid, but parathyroid like hormone, that is still doing the job to increase the calcium levels in the body. But this is going to actually suppress the parathyroid gland. So the real parathyroid levels will be low if the malignancy is outside the domain of the parathyroid gland. Okay, that's an important concept which they test in exam quite a lot. Primary hyperparathyroidism traditionally has been associated with constellation of symptoms including painful bones, renal stones, abdominal groans, and psychic moans, all associated with increased calcium levels. So, calcium being released from the bone, so osteolytic lesions, painful bones, renal stones because you have more calcium now, abdominal groans because increased calcium, constipation, and psychic moans. So that's a very common, jargon that is used. Pain secondary to fractures of the bone weakened by osteoporosis or osteitis fibrosis cystica and resulting from renal stones, obstructive. So that is all has been covered if you remember only this particular thing. Additional signs and symptoms that may be encountered in some cases include the following: GI disturbances. Constipation is very common. Peptic ulcers can happen. Pancreatitis also because of the gallstones. Okay. CNS, there will be depression, seizures, lethargy, neuromuscular. There will be weakness and hypotonia of the muscles, and the person feel polyuria. Go to the loo again and again, and because the person is losing a lot of water, there is polydipsia. Okay. Although some of these alterations are clearly related to hypercalcemia, and the pathophysiology of many of the other manifestations remain poorly understood. So actually many of them are being explained just by increased calcium levels. So if you understand pathophysiology, you understand everything else. So remember, when we talk about primary hyperparathyroidism, there is something wrong within the parathyroid gland. And what is wrong? It is either an adenoma or a primary hyperplasia or a parathyroid carcinoma. So the picture clinical serum profile would be increased PTH and increased calciums. Okay, so that's sort of a story. Now let's talk about secondary hyperparathyroidism. It is caused by chronic depression of serum calcium levels, most often result because of the renal failure, leading to now compensatory overactivity of the parathyroid. So intrinsically, there is nothing wrong within the parathyroid glands, but there is something wrong somewhere else. So kidney's job is to absorb calcium, for example. So if there is chronic renal failure, kidney is not performing the job, and the lower levels of calcium are experienced by the body, and low levels of calcium are a stimulus for parathyroid gland to release PTH so that calcium levels can go back up. So actually the problem lies within the kidney, and because of kidney's problem, parathyroid glands are simply trying to compensate the low calcium levels. Okay, the mechanism by which the chronic renal failure induces secondary hyper are complex and not fully understood, but to me it's pretty simple, because if kidney is not working, calcium levels are disturbed, and that is enough stimulus for parathyroid. Chronic renal insufficiency is associated with decreased phosphate excretion, which in turn results in hyperphosphatemia, and hyperphosphatemia would mean lowering the calcium level, because phosphate will bind with calcium, and that is another stimulus. Okay, and the kidney is also not activating then vitamin D. So all the jobs of kidney associated with maintaining calcium levels will be disturbed. Calcium not being absorbed, phosphate not being excreted, vitamin D not being activated, all will cause low calcium in the blood, and low calcium will stimulate parathyroids. Okay, and the clinical manifestation of these patients would be they're dominated by those related to chronic renal failure rather than hypercalcemia. There are bone abnormalities, osteodystrophy because of renal problem, and obviously you see all sort of other renal associated problems as well. Serum calcium remains nearly normal because it is a compensatory increase in PTH. It is not an inherent increase in PTH. So most of the time the serum calcium levels are actually not very high. They are brought back to the normal. So remember the physiology. If there is something wrong with the kidney and the parathyroid are there to compensate, so kidney के problem की वजह से calcium level is going down, but this is stimulating parathyroid to release PTH to bring the calcium levels up to the normal, not above the normal. Okay, that's an important concept. If there was something wrong intrinsically within the parathyroid gland, then the PTH does not care if the calcium is normal or above normal. Therefore, the PTH continues to release and the calcium levels are always above normal. So increased calcium levels, increased PTH, we are talking about primary hyperparathyroidism, okay? Normal calcium perhaps and slightly increased or sometimes even normal levels of PTH, we are talking about secondary hyperparathyroidism, right? There may be metastatic calcification of the blood vessel because sometimes calcium level is, obviously it's disturbed, so there are spikes of high calcium and low calcium. And then there are calcium deposits in other parts of the body as well, such as the skin and other organs, and that is known as calciphylaxis. And a minority of patients with parathyroid activity may be, they may become autonomous, and now there will be hypercalcemia. So, बार-बार इसको जब stimulate करेंगे, so there comes a time that it at one point starts secreting a lot of PTH. Simple as that, okay? And now this mechanism is known as tertiary hyperparathyroidism. Now, so there is a difference. You may say कि ये parathyroid gland है, ये kidneys हैं, kidneys में damage हुआ तो parathyroid ने over compensation के लिए PTH का level increase किया, and this is called secondary. Now there comes a point कि ये काम कर करके इतना bizarre हो गया कि now there is over inert or inherent increase in PTH. Now it is no more linked to the kidney disorder, but it is now its own autonomous हो गया ये system. अब आप कहेंगे ये तो primary बन गया. नहीं, ये primary तो बना, लेकिन initial pathology within the parathyroid नहीं थी. ये इसका दिमाग खराब हुआ है. It is now converted into an animal. Well, that's a movie in the trend these days. It is now converted into an animal just because it was initiated by kidney. So if the gland becomes autonomous and it starts secreting a lot of PTH after being a victim of secondary hyperparathyroidism, this phenomenon now is known as tertiary hyperparathyroidism. Okay, so that's a very important concept for you to understand. Now, a few things about the morphology. The morphologic changes in the primary hyperparathyroidism include those in the parathyroid gland, obviously, because that is where the pathology starts, okay? And 75 to 80% of the cases, there is a solitary adenoma. There is a single adenoma. By definition, parathyroid adenomas are confined to a single gland. They are not multiple gland occupancy, okay? The other gland may be normal in size or actually somewhat shrunken. So if you look here, so there are 4 glands. This one is the one which is affected. So that's an important point to understand, okay? Now, if there is atypia and other tumor stuff, then you may be thinking more about cancers. Parathyroid hyperplasia is typically multi-glandular process. So, adenoma, by definition, is usually confined to a single gland, but hyperplasia is usually confined to multiple glands. That's an important point. Okay. Then the carcinomas may be circumcised lesions. They are difficult to actually distinguish from adenomas or maybe clearly invasive neoplasm. So it can present as a solitary nodule or maybe an invading tumor. This is a general agreement that the diagnosis of carcinoma based on cytological details. Obviously, you need to put the needle in, take the cells out and see what they are looking like. Okay. Then, obviously, there will be changes in other parts of the body, all related to increased calcium, and this involves skeletal changes. There will be osteolytic lesions, or there will be foci of hemorrhage. So, if this is the bone and you are taking calcium out of it, there will be foci of cyst and, bleeding and all these things. So, that condition is called osteitis fibrosa cystica. Okay? And, therefore, another name given to this thing is sometimes it was taken wrongly as a neoplasm and has a funny name called brown tumors of brown because they are bleeding and hemorrhagic, and tumors because they look cystic, cavitating, and because there is hyperparathyroidism. Okay, there will be renal changes if there is increased calcium, renal stones, nephrolithiasis or nephrocalcinosis, and there can be metastatic calcification of other parts of the body including lungs and stomach and whatnot. Okay, all very important. Now that's before that, do I have anything else to tell? So secondary hyperparathyroidism may the hyperparathyroid is obviously hyperplastic because it is responding to problems within the kidney. As in primary hyperplasia, the degree of glandular enlargement is not necessarily symmetric. So one gland may be affected, others may not be. There are bone changes, metastatic calcification, all these things are present there. And the chief cells may be more abundant. They have more clear cytoplasm, calling them water clear cells. So that's all. Last thing that I have to talk about hyperparathyroidism is this particular table where they are talking about different causes. Okay, so increased PTH will be seen in primary hyperparathyroidism, obviously, and decreased PTH will be seen in so many other conditions. So you actually have to understand that there are other than parathyroid causes of parathyroid disturbance as well. Particularly if you look here, there are so many things which are actually causing the PTH levels to go down. And look here, vitamin D intoxication, immobilization, some drugs, thiazides for example, granulomatous disease, sarcoidosis. Now many students mark this wrong, but sarcoidosis is associated with decreased PTH levels. So I would say this is a good high yield table for you. And please try and understand that increased PTH will be a phenomena at some point in the disease progression in all of the forms of hyperparathyroidism. So primary hyperparathyroidism, obviously, there will be increased PTH. In secondary, there will be normal to increased PTH. In tertiary, there will be increased PTH. So increased PTH is a phenomena of all the parathyroid associated problems. But decreased PTH are more associated with other stuff, drugs, immobilization, vitamin D intoxication, okay? And also, if there is parathyroid hormone related peptide, so this may be related by a lung tumor, for example. In that case, this particular peptide being secreted by lung tumor will be causing hypercalcemia, but it will be inhibiting the PTH level. So PTH levels will be down and there will be signs and symptoms of hypercalcemia. So try to think like these about these concepts. Okay, now in the next video we are going to touch upon the hypoparathyroidism. So we are done with hyperparathyroidism. I hope you liked the video. If you did, please share with your colleagues and subscribe the channel. This is Professor Asif Qureshi and you are watching Dr. Asif Lectures.